Welcome back to the deep dive. Our mission today is to really get into one of medicine's most complex puzzles. Systemic lupus erythematosus, you probably know it as SLE. For anyone wanting a quick grasp or, if you're digging into pathology, SLE is. It's absolutely central.
It really is the prototype. When we talk about systemic autoimmune disease, meaning the immune system isn't just hitting one spot, it's targeting antigens all over across multiple organs.
Okay.
Well, SLE is the definition we turn to.
Okay.
Today, we're going to trace it from the very beginning. That microscopic failure of self-tolerance, right up to, the visible damage it causes, especially the kidneys. That's key.
Okay, let's unpack that first bit. Systemic versus organ specific. So like if someone has type 1 diabetes, the immune system is focused, right? Laser beam on the pancreas beta cells.
Exactly. Very targeted.
So if SLE is systemic, how does the attack actually work differently? Is it the same kind of attack, just broader?
That's a great question. And it's fundamentally different. In SLE, the main problem isn't usually a direct cell-on-cell attack, like a type 5e hypersensitivity. Not primarily, anyway.
Okay.
The disease is really defined by this huge variety of autoantibodies. Antibodies against the body's own stuff, especially anti-nuclear antibodies, ANAs. They target everything inside the cell nucleus, DNA, histone proteins, you name it.
Right.
And these antibodies, they grab onto those self-antigens when they get released from damaged cells, and they form clumps. We call them immune complexes.
Ah, so that's the type 3 hypersensitivity mechanism we hear about.
Precisely. These immune complexes,
Yeah.
they're circulating in the blood and they get stuck. They get trapped in the tiny blood vessel walls, in the filtering membranes of the kidneys, joints, skin.
All over the place.
Big sludge building up in the pipes.
Kind of, yeah. And once they're deposited, they act like little alarm bells. They trigger the complement system, part of the innate immune system, and that sets off this massive, relentless inflammation right there in the tissue.
So it's less like a sniper attack on one target.
Right.
And like indiscriminate bombing caused by these complexes landing everywhere.
That's a good way to put it. It's collateral damage from this immune complex spill. And that generalized complement-driven inflammation is why SLE can hit almost any organ system. Skin, brain, heart, lungs, you name it.
But while it can hit anywhere, the damage tends to show up most clearly in certain places, right?
Yeah.
Places with lots of blood flow or filtration.
Exactly. You see the most prominent injury in the skin, definitely. The joints, absolutely. The serosal membranes, that's the lining around the heart and lungs. And critically, the kidneys.
Okay. Before we get into how the body even starts making these autoantibodies, we have to talk about who gets this disease.
Yeah.
The sources really highlight a dramatic skew. It's not random.
No, definitely not. The demographics are, well, they're striking. Overall prevalence can be up to 1 in 2,500 in some populations, which is quite high for an autoimmune disease.
Wow.
But the gender bias is just profound, especially during the reproductive years, say between 17 and 55.
We see a female-to-male ratio of about 9 to 1.
9 to 1. That's huge. It strongly suggests hormones are involved, right?
Absolutely. The thinking is that estrogen and other hormonal factors play a significant role, though the exact mechanisms are still being worked out. It's an area of intense research.
Does that ratio change outside of those years, like in kids or older adults?
It does, which again points towards that hormone connection. If SLE develops in childhood or after age 65 or so, the ratio drops quite a bit. It's closer to 2 or maybe 3 to 1, still more common in females, but not that extreme 9.1.
Interesting.
And then there's the racial disparity. The prevalence is significantly higher, maybe 2 to 3-fold higher in individuals who are Black or Hispanic compared to white populations.
So genetics underlying that, or environmental factors, or both?
Likely both. There's definitely a strong genetic component, which we'll get into, but environmental factors and possibly socioeconomic factors might also contribute to those differences. It's complex.
Okay, so you've got this disease that can look like almost anything, affecting potentially any organ, and it has these strong demographic skews. Diagnosis must be incredibly difficult.
Oh, it is. It's notoriously challenging.
Yeah.
SLE is often called the great imitator because its symptoms can mimic so many other conditions. You can't just rely on one single symptom or test.
So how do clinicians approach it?
That's where formal classification criteria come in. Groups like the American College of Rheumatology, ACR, and the Systemic Lupus International Collaborating Clinics, SLICC, have developed these. They're not perfect for instant diagnosis in every single early case, but they help classify patients for research and ensure consistency.
Right.
Generally, a patient is classified as having SLE if they meet a certain number of criteria, usually 4 or more, And crucially, these have to include at least one clinical finding and one immunologic finding.
Okay, let's give people listening a feel for that roadmap. What kind of things fall under the clinical criteria bucket?
Sure. Clinically, there are some really classic signs. The most visible one is probably the malar rash, the butterfly rash across the cheeks and the bridge of the nose. It's red, sometimes raised.
Uh-huh.
Related to skin is photosensitivity. So exposure to UV light, like sunlight, triggers or worsens the skin rash, or even systemic symptoms. Big flag.
Okay, what about internally?
Internally, we look for joint involvement, usually non-erosive arthritis or synovitis. That means the joints are inflamed, painful, swollen, but, and this is key,
Mm-hmm.
they typically don't have the kind of progressive bone destruction you see in, say, rheumatoid arthritis.
So painful, but not usually deforming in the same way.
Generally, yes.
Yeah.
Then there's serositis. That's inflammation of those linings we mentioned. Pleuritis, inflammation around the lungs, or pericarditis around the heart, can cause chest pain, especially with breathing.
And the kidneys, you said, are critical?
Absolutely vital. Any sign of renal disorder is a major criterion. This is usually picked up by finding persistent protein in the urine, called proteinuria, or seeing abnormal cellular counts in the urine sediment under a microscope. Both point to kidney damage from those immune complexes.
Okay.
And finally, under clinical, there are hematologic changes. Low white blood cell counts, leukopenia, low platelet counts, thrombocytopenia, or a specific type of anemia where red blood cells are destroyed by antibodies, hemolytic anemia. We'll talk more about why those happen later. It's actually a different mechanism. Type 2 hypersensitivity.
Got it. So that's a lot on the clinical side. What about the immunologic side, the lab tests?
This is where we look for the specific weapons the immune system is deploying. The first, and most common, is an abnormal titer of anti-nuclear antibodies.
ANAs.
Almost everyone with SLE, something like 95 to 100%, tests positive for ANAs. It's a very sensitive test, but not very specific on its own genidations. Can cause positive ANAs.
So a positive ANA gets your attention, but doesn't seal the deal.
Exactly.
Yeah.
You need the more specific markers. The big two are antibodies against double-stranded DNA, anti-dsDNA, and antibodies against the Smith antigen, anti-SMA.
How specific are those?
Very. Anti-dsDNA is highly specific for SLE, and its levels often correlate with disease activity, especially kidney involvement. Anti-SMA antibody. Finding that is considered virtually diagnostic for SLE. It's extremely specific.
Wow.
We also test for antiphospholipid antibodies. These are important because they're linked to a specific problem with blood clotting, which we'll definitely circle back to.
Okay, fantastic overview of the what. Now let's get to the why. We have these autoantibodies, these immune complexes. Why did the immune system go rogue in the first place? Why did that fundamental ability to tolerate self break down?
That failure of self-tolerance, it's the absolute root cause, not just for SLE, but for all autoimmune diseases. Normally, our immune system's trained very carefully not to attack our own cells and tissues. In SLE, that training process or the maintenance of that tolerance fails at multiple levels.
Multiple levels, so not just one single mistake.
Right. We think about it in terms of central tolerance and peripheral tolerance.
Okay, walk us through that. Where does central tolerance happen?
Central tolerance is like the immune system's basic training academy. It happens where lymphocytes are born and, sure, T cells in the thymus, B cells in the bone marrow.
Right.
As these young immune cells develop, they're tested. If a developing T cell or B cell shows strong reactivity against a self-antigen presented to it right there in the thymus or bone marrow, it's supposed to be eliminated. It gets a signal to undergo programmed cell death, apoptosis.
That's called negative selection or clonal dilution.
Exactly. Delete the dangerous ones before they even get out. For B cells, there's also a cool backup plan called receptor editing. If a B cell makes a self-reactive antibody receptor, it gets the chance to reshuffle its genes and try to make a different non-self-reactive receptor.
Okay, so the body tries hard to weed out the bad actors early on.
It does. But the system isn't perfect. It can't possibly show these developing cells every single self-antigen that exists in the body. So inevitably, some weakly self-reactive T and B cells manage to graduate and escape into the circulation.
And that's where peripheral tolerance comes in, like the police force patrolling the streets after basic training.
That's a great analogy. Peripheral tolerance consists of several mechanisms out in the rest of the body designed to silence or eliminate those escaped self-reactive cells before they can cause trouble. And it's really the failure of these peripheral mechanisms that seems to be critical in allowing SLE to develop and persist.
Okay, what are those key peripheral mechanisms that break down in SLE?
There are three main ones to think about. First is anergy.
Energy. Define that for us simply.
Anergy basically means the cell is turned off, it's functionally unresponsive. Imagine a T cell out in the body, encounters a self-antigen presented by a regular tissue cell. For that T cell to get fully activated and dangerous, it needs two signals. Signal 1 is recognizing the antigen. Signal 2 is a go signal, a co-stimulatory signal, usually delivered when a molecule called B7 on the antigen-presenting cell binds to a molecule called CD28 on the T cell. Most normal tissue cells don't express B7. So if a self-reactive T cell gets signal 1, sees self-antigen, but doesn't get signal 2, no B7-CD28 handshake, it doesn't activate. Instead, it enters this state of energy. It's alive, but it can't initiate an attack.
Like having the key to the car, but the battery's dead.
Perfect analogy. The cell recognizes self, but is rendered harmless.
And the body has ways to actively shut down T cells too, right? Using different receptors.
Yes, absolutely. Instead of activating CD28, T cells can express inhibitory receptors. The key ones are CTLA4 and PD-1. When these receptors bind to B7 or related molecules, they send a stop signal into the T cell, actively preventing activation.
CTLA4, PD-1. Those sound familiar from cancer immunotherapy.
They are. In cancer treatment, we use drugs to block CTLA4 and PD-1. Why? To release the brakes on the immune system so it can attack the tumor more effectively.
Wow. So blocking those brakes helps fight cancer. But if someone have a natural defect in CTLA4, like certain inherited mutations,
they get severe, widespread autoimmunity, sometimes resembling SLE. It perfectly illustrates this incredibly fine balance the immune system has to maintain. Too little activity, you get cancer or infection. Too much, you get autoimmunity.
That really drives it home. Okay, so energy failure is one mechanism. What's the second peripheral tolerance breakdown?
The second is failure of deletion by apoptosis. Even mature T cells, if they repeatedly encounter self-antigen, especially without that co-stimulation, can be instructed to die. A key pathway for this death signal involves a receptor called FAS and its partner, FAS ligand, FAS-L.
Okay.
If a T cell expresses FAS and another cell expresses FAS, they bind, and it tells the FAS-bearing T cell to undergo apoptosis.
Oh.
Now, if there are mutations in the genes for FAS-LS or 5-self-dollars, that death signal can't be delivered properly.
It happens then.
Self-reactive lymphocytes that should have been deleted stick around. And this leads to a condition called autoimmune lymphoproliferative syndrome, or ALPS. Patients with ALPS have massive lymph node swelling, enlarged spleens, and, crucially, autoimmune attacks, often with autoantibodies very similar to those seen in SLE.
So another specific genetic defect linking directly to SLE-like symptoms.
Exactly. And the third major mechanism involves a specialized type of T cell whose whole job is to keep things quiet.
The regulatory T cells, or TREGs.
Those are the ones. TREGs are like the immune system's own internal police force. They actively suppress the activation and function of other immune cells, including those self-reactive T cells that escape central tolerance. They're characterized by a key transcription factor called FOXP3 and often express high levels of the IL-2 receptor, CD25.
How do they suppress other cells?
They can do it in several ways. They can secrete inhibitory signaling molecules like the cytokines IL-10 and TGF-beta. They can act like sponges, soaking up growth factors like IL-2 that other T cells need to proliferate. They can even directly kill other immune cells.
And if TREGs don't work properly?
Big trouble. There's a rare but devastating genetic disease called IPEX syndrome caused by mutations in the FOXP3 gene. These individuals completely lack functional TREGs, and they suffer from catastrophic multi-organ autoimmunity early in life. In SLE, it's usually not a complete absence, but studies show that TREG numbers, or more importantly, their suppressive function, can be significantly impaired. This allows those self-reactive lymphocytes to run wild.
Okay, so we have failures possible at the central deletion stage, and then failures in peripheral anergy, peripheral deletion, and trig suppression. It's like the system has multiple safety nets, but in SLE, several of them might be frayed or broken.
That's a very good way to think about it. It's rarely just one thing. It's likely a combination of weaknesses in these tolerance mechanisms.
Now, this clearly points to a genetic basis for these weaknesses, but it's not purely genetic, right? You look at identical twins, they share 100% of their genes, but if one twin has SLE, the chance of the other twin getting it is what, around 20–25%?
Exactly. That concordance rate for monozygotic twins, around 20%, maybe a bit higher in some studies, tells us two crucial things. First, genetics plays a very strong role. 20% is much, much higher than the risk in dizygotic non-identical twins, which is only about 1–3%, or the general population risk.
Right.
But second, the fact that it's not 100% tells us that genetics alone isn't enough. Environmental factors must play a critical role in triggering the disease in genetically susceptible individuals. Genetics loads the gun, environment pulls the trigger.
Let's talk about the genetics first. What specific genes are implicated? We hear about HLA types a lot.
The MHC complex, which encodes the HLA molecules, is definitely involved. Specific HLA alleles, particularly certain HLA-DR types like DRB10301011 and DRB1050101, seem to be associated with increased risk of SLE.
And how do these HLA types actually contribute?
Remember, HLA molecules are the structures on antigen-presenting cells that display peptide fragments to T cells. The thinking is that these particular HLA variants might be better at binding and presenting certain self-peptides, maybe peptides derived from nuclear antigens, in a way that makes them more likely to be recognized as foreign by those weakly self-reactive T cells we talked about. This could predispose someone to making specific autoantibodies.
Okay, so HLA influences what the immune system sees, but you mentioned earlier that some of the most interesting genetic links relate less to recognizing the enemy and more to cleaning up the battlefield.
Yes, this is a really crucial insight, and it ties directly back to that type 3 immune complex mechanism. There's a strong association between SLE and inherited deficiencies in some of the early components of the complement system, specifically deficiencies in C1q, C2, and C4.
Why are those particular complement proteins so important here?
They have two critical jobs, besides just triggering inflammation later on. First, C1q, C4, and C2 are essential for properly processing and clearing circulating immune complexes before they get trapped in tissues. They help keep them soluble and tag them for removal by phagocytic cells.
Okay, job one, clear immune complexes.
Job two. They're also vital for the efficient clearance of apoptotic cells, cells undergoing programmed death. C1q in particular can bind directly to the surface of dying cells, marking them for rapid engulfment by phagocytes.
So if you have a deficiency in C1q, C2, or C4?
Two bad things happen. One, immune complexes hang around longer in the circulation, increasing the chance that they'll deposit in tissues like the kidney. Two, apoptotic cells aren't cleared efficiently. They linger, break down, and spill their contents, including all those nuclear antigens like DNA and histones, into the surrounding environment.
So the genetic defect literally causes the trash the antigens to pile up, making it more likely the immune system will see it and react.
Precisely. This failure of waste disposal creates a rich source of the very autoantigens that drive the disease. It creates the perfect storm. You have underlying weaknesses in tolerance, and you have an excess supply of the antigens those faulty immune cells might react to. This really sets the stage for environmental triggers to push things over the edge.
Okay, let's talk triggers. The classic one everyone mentions with lupus is sunlight, UV light. How does a trip to the beach cause a potentially life-threatening flare?
It's a fascinating and pretty well understood mechanism now. UV radiation, especially UVD, is directly damaging to skin cells. Significant exposure causes widespread apoptosis, programmed cell death in the epidermis.
Okay, mass cell death in the skin.
Now, normally those dying cells would be quickly gobbled up by phagocytes, thanks in part to that complement tagging system we just discussed. But in someone genetically predisposed to SLE, maybe with that C1q deficiency or other clearance defects, that cleanup is slow and inefficient.
So the apoptotic debris hangs around.
Yes. And importantly, this debris includes large amounts of nuclear material DNA, RNA, histones released from the dying cells. These nuclear antigens accumulate in the skin tissue.
And this is where that mistaken identity comes in, the phantom virus idea.
Exactly. These self-derived nucleic acids, our own DNA and RNA, are chemically very similar to the nucleic acids found inside viruses and bacteria. Our immune system has evolved specialized internal sensors to detect microbial nucleic acids as a sign of infection. These sensors are the toll-like receptors, or TLRs. Specifically, TLR9 recognizes DNA, and TLR7 recognizes RNA.
They're usually inside the cell, right? Waiting for signs of intracellular infection.
Correct. They're located in intracellular compartments called endosomes. So when those lingering nuclear antigens in the skin get taken up by antigen-presenting cells, like dendritic cells or B cells, they end up inside the endosomes, right, where TLR7 and TLR9 are waiting.
And the TLRs see this self-DNA and think, virus.
Essentially, yes. The body mistakes its own cellular debris, triggered by UV light, for an invading pathogen. This TLR activation then leads to a massive downstream inflammatory response, including the production of type I interferons, which we'll come back to, further activating the immune system and worsening the lupus flare. It's a direct link from sunlight to inflammation via mistaken identity.
Are there other environmental triggers thought to work similarly or through different mechanisms?
Yeah, infections themselves are a major suspect, not necessarily by causing direct damage like UV, but through a couple of potential mechanisms. One is molecular mimicry. The idea here is that a protein on a bacteria or virus might happen to look very similar structurally to one of our own self-proteins.
Okay.
So the immune system mounts a perfectly normal response to the microbe, but the antibodies or T cells generated might accidentally cross-react with the similar-looking self-protein, initiating autoimmunity.
And the other infection mechanism?
It's called bystander activation. During an infection, the local environment becomes highly inflammatory. Antigen-presenting cells get activated and start expressing those costimulatory molecules, like B7 that we talked about.
A signal too.
Right. Now, imagine a self-reactive T cell that was previously harmless because it only got signal 1, seeing self-antigen, happens to be nearby. In this inflamed environment, it might now encounter an activated APC presenting self-antigen with B7 costimulation. Suddenly, it gets both signal 1 and signal 2, overcoming energy and becoming activated against self. The infection provides the danger context that pushes it over the edge.
Fascinating. We also have to mention drug-induced lupus erythematosus, DIL. Certain medications, hydralazine, procainamide, are the classic ones, can cause lupus-like symptoms. Is this the same disease process?
It's related but distinct, which is important clinically. People with DIL can develop symptoms like joint pain, muscle pain, fever, serositis, and they definitely develop NAs. But critically, they rarely get the severe organ involvement, especially kidney disease or CNS disease that we see in spontaneous SLE.
And the antibody profile is different too.
Yes, very different. DIL is strongly associated with antibodies specifically against histones, those proteins that package DNA. In fact, almost everyone with DIL has antihistone antibodies. However, they very rarely develop antibodies to double-stranded DNA or the germ antigen, which are the hallmarks of spontaneous SLE.
And does it go away if you stop the drug?
Usually, yes. Once the offending drug is stopped, the symptoms and the antibodies typically resolve over weeks or months. This helps distinguish it from the chronic, persistent nature of spontaneous SLE.
Okay, that brings us back squarely to the antibodies in spontaneous SLE. You said ANAs are the hallmark. How are they actually detected and interpreted in the lab?
The standard screening test is indirect immunofluorescence, IF, on specific cell lines, usually HEP2 cells. Basically, you take the patient's serum, which contains their antibodies, apply it to these cells on a slide, and then add a secondary antibody tagged with the fluorescent dye that binds to human antibodies.
So if the patient has antibodies binding to the cell nucleus, it lights up under the microscope.
Exactly. And the pattern of the fluorescence tells you something about what nuclear components the antibodies might be targeting.
What are the main patterns?
There are several, but 3 main ones give important clues. A homogeneous or diffuse pattern means the entire nucleus lights up smoothly. This pattern is often associated with antibodies to chromatin, histones, and sometimes double-stranded DNA. It's quite common in SLE.
Okay.
A rim or peripheral pattern shows the fluorescence concentrated on the edge of the nucleus like a ring. This pattern is highly suggestive of antibodies against double-stranded DNA, again, very relevant for SLE.
Right.
Then there's the speckled pattern. This looks like, well, speckles or dots scattered throughout the nucleus, sparing the nucleoli, the dark spots inside. This is actually the most common pattern seen overall, but it's the least specific. It can be caused by antibodies to a wide range of non-DNA nuclear antigens, including CMA, RNP, SSA, SSB, some associated with SLE, others with different autoimmune diseases like Sjogren's or scleroderma.
So the pattern gives clues, but you still need the specific tests for anti-dsDNA and anti-sesam to really pin down SLE.
Absolutely. The IF-ANA pattern guides further testing. Finding those highly specific anti-dsDNA and anti-Sim antibodies is crucial for diagnosis. Remember, anti-dsDNA often correlates with disease activity, especially kidney disease, making it useful for monitoring too. And anti-Silism is so specific, its presence really clinches the SLE diagnosis.
Now, what about those antiphospholipid antibodies, APLs, you mentioned earlier, found in maybe 30–40% of SLE patients? What do they target?
They're a bit unusual. They don't target phospholipids directly, but rather proteins that are bound to phospholipids on cell membranes. The main target is a protein called beta-2-glycoprotein I, but others include proteins involved in coagulation like prothrombin.
And this leads to that famous paradox.
Exactly. The paradox is what happens in the lab versus in the patient. Some of these APLs interfere with standard laboratory clotting tests that use phospholipid reagents. They make the clotting time longer in the test tube. Because of this artifact, they were initially called lupus anticoagulants.
Anticoagulant? Sounds like they prevent clotting.
That's the irony. Because in vivo, inside the patient's body, these antibodies do the exact opposite. They promote clotting. They create a hypercoagulable state.
Wow, so they cause too much clotting. That sounds dangerous.
It is incredibly dangerous. This hypercoagulability leads to a significantly increased risk of both arterial and venous thrombosis blood clots. This can manifest as deep vein thrombosis, DVT in the legs, pulmonary embolism if clots travel to the lungs, strokes if clots form in brain arteries, and even recurrent miscarriages due to clots forming in the placental vessels.
So if a patient has SLE and these clinical problems like clotting or recurrent pregnancy loss, along with the APL antibodies?
That's defined as secondary antiphospholipid antibody syndrome, APS. Secondary because it's occurring in the context of another disease, SLE. If someone has the clinical events and the antibodies but doesn't meet the criteria for SLE, that's called primary APS. Either way, it often requires long-term treatment with anticoagulant medications like warfarin or heparin to prevent devastating clots.
Okay, a really critical subset of patients to identify. We've covered the why, the tolerance failure, the genetics, the triggers, and the weapons, the autoantibodies. Now let's focus on the damage. How do these processes actually injure tissues? You said type 3 hypersensitivity is the main driver.
For most of the systemic lesions, the damage in the kidneys, blood vessels, skin, joints, yes, it's primarily type 3. Those circulating DNA, anti-DNA complexes, and others deposit in the small vessel walls. That deposition activates complement right there in the tissue.
And complement activation triggers inflammation.
Right. Complement activation releases pro-inflammatory fragments, like C3a and C5a, that attract neutrophils and macrophages to the site. These inflammatory cells arrive, release destructive enzymes and reactive oxygen species, and you get tissue damage. This process also consumes complement components, which is why measuring low serum complement levels, C3, C4, hypocomplementemia, can be a useful marker of active immune complex-mediated disease in SLE.
But you also mentioned type 2 hypersensitivity earlier, specifically for the blood cell problems.
Correct. The low blood counts, hemolytic anemia, thrombocytopenia, leukopenia, are typically caused by a type 2 mechanism. Here, antibodies are directed against antigens on the surface of the blood cells themselves.
So antibodies sticking directly to red cells or platelets.
Exactly. These antibodies act like tags, a process called opsonization. They mark the coded cells for destruction by phagocytic cells, primarily in the spleen. The immune system essentially eats its own blood cells. Immune thrombocytopenic purpura, ITP, where platelets are destroyed, is a classic example of this type 2 process, and it can actually be the first sign of SLE in some patients, maybe up to 10%.
And quickly, what about the LE cell? It's mentioned in older texts. Is it related to these processes?
It is, pathologically. It's mostly of historical interest now, as we rely on more specific antibody tests. But it's one of the first specific laboratory findings for SLE. An LE body is basically the nucleus of a damaged cell that has reacted with ANAs, becoming swollen and losing its structure. An LE cell is typically a neutrophil, a type of phagocyte that has actually engulfed one of these LE bodies. Seeing LE cells in a patient's blood smear was visual proof of this intense anti-nuclear attack happening in the body.
Fascinating piece of history. Okay, let's turn to the organ system that often determines the long-term outcome. The kidneys, lupus nephritis. You said up to 70% of patients have kidney involvement.
Yes, the kidney is a major target. And the severity of kidney damage is probably the single most important predictor of overall prognosis in SLE. Understanding lupus nephritis is absolutely key.
How is the damage classified? Is it all the same type of injury?
No, definitely not. The pattern of injury is crucial for guiding treatment and predicting outcome. The International Society of Nephrology Pathology Society, ISNRPS, has established a classification system based on kidney biopsy findings, primarily looking at where the immune complexes are deposited and what kind of reaction they're causing in the glomeruli, the kidney's filtering units. There are 6 classes.
6 classes. Okay, can you walk us through them, maybe highlighting the most common or most severe ones?
Absolutely. We go from mildest to most severe. Class 1, minimal mesangial lupus nephritis. This is the mildest form, and actually not that common on biopsy because patients are often asymptomatic. Immune deposits are found only in the mesangium, that central stalk supporting the glomerular capillaries. Under a regular light microscope, the glomeruli look pretty much normal. Class 2, mesangial proliferative lupus nephritis. Still mostly mild. Deposits are again confined to the mesangium, but now there's some proliferation, some increase in the number of mesangial cells. Patients might have tiny amounts of blood, microscopic hematuria, or protein in their urine, but kidney function is usually normal.
So classes 1 and 2 are relatively contained within that mesangial area.
Right. Things get more serious, starting with class 3. Class 3, focal lupus nephritis. Focal is the key word here. Now, the immune deposits are not just in the mesangium, but also in the subendothelial space, meaning under the lining of the glomerular capillaries themselves. And there's inflammation and proliferation within the capillaries. But crucially, it affects less than 50% of the total glomeruli seen on the biopsy.
Okay, so damage is spreading, but it's patchy.
Exactly. Which leads us to the most common severe form. Class 4, diffuse lupus nephritis. This is the big one. Diffuse means the same kind of injury as Class 3, subendothelial deposits, capillary inflammation proliferation, is now affecting 50% or more of the glomeruli. This is the most frequent pattern seen in patients who present with significant kidney problems, and it carries the worst prognosis if not treated aggressively.
And this is where we see that classic pathological finding, the wire loop lesions. What exactly are those?
Yes, wire loops are characteristic of Class 4. They represent massive, thick deposits of immune complexes accumulating in that subendothelial space. They essentially thicken the entire capillary wall, making it look like a rigid, thickened wire loop under the microscope.
And that thickening must severely impair kidney function.
Absolutely. It obstructs blood flow, damages the filtration barrier. Patients with Class 2 typically have significant hematuria, blood in urine, proteinuria, often heavy, sometimes reaching nephrotic syndrome levels, hypertension, and frequently declining kidney function, renal insufficiency. This form often progresses rapidly to scarring if treatment isn't initiated quickly.
Okay, so Class 4 is diffuse and proliferative, mainly subendothelial. What's Class V?
Class V, membranous lupus nephritis. This is different. Here, the predominant deposits are subepithelial, meaning they're on the outer side of the capillary wall, between the basement membrane and the podocytes, the cells wrapping the capillaries. While Class 4 is defined by proliferation, Class V is defined by this thickening of the capillary wall due to these outer deposits. It often presents with severe proteinuria, classic nephrotic syndrome. Sometimes Class V can occur together with Class 3 or 4.
And finally, Class 6.
Class 6, advanced sclerosing lupus nephritis. This is essentially end-stage kidney disease due to lupus, where the 90% of the glomeruli are scarred, sclerotic. There's little active inflammation left, just widespread irreversible damage. At this point, patients typically require dialysis or kidney transplantation.
Wow. That classification really highlights how critical a kidney biopsy is for guiding treatment in lupus.
Indispensable. You treat Class 2 very differently from Class 4 or Class V. Biopsy is essential.
Okay, moving away from the kidneys, let's touch on the skin and joints. Again, very common sites. The butterfly rash, photosensitivity. What's happening histologically in the skin?
If you biopsy the rash, you typically see a couple of things. Inflammation around blood vessels and hair follicles in the dermis, damage to the basal cell layer of the epidermis, the deepest layer called vacuolar degeneration, and crucially, if you use immunofluorescence on the biopsy.
You see immune deposits.
Yes. You see deposits of immunoglobulin, like IgG, and complement components like C3, in a granular band right along the dermo-epidermal junction, the boundary between the epidermis and dermis. This is direct evidence of those immune complexes causing damage in the skin. Interestingly, you can sometimes find these deposits even in sun-exposed skin that looks normal, the so-called lupus band test.
And the joints. 80–90% of patients have pain or swelling.
Yeah.
You stressed it's usually non-erosive synovitis. Can you elaborate?
Right. So patients get inflammation of the synovial membrane lining the joint, causing pain, stiffness, and swelling, much like rheumatoid arthritis, RA. However, unlike RA, the inflammation in SLE typically doesn't lead to significant erosion of the cartilage and underlying bone.
Why the difference?
It's thought that the inflammation in SLE joints is primarily driven by those transient immune complex deposits, causing inflammation that comes and goes, whereas in RA there's a more sustained destructive cellular process involving activated T cells and macrophages that directly attack the joint structures. So while lupus arthritis can be very painful and debilitating during flares, it generally doesn't cause the severe, permanent joint deformities often seen in long-standing RA.
Got it. What about the heart? We mentioned pericarditis, inflammation of the sac is common. Any other specific cardiac issues in SLE?
Yes, the classic, though less common now, finding is Lehmann-Sachs endocarditis.
Endocarditis, inflammation of the heart valves.
Exactly. But this is a non-bacterial endocarditis. It's characterized by small warty vegetations, clumps of immune complexes and fibrin that can form on the heart valves, most often the mitral or aortic valve.
What's unique about them?
What's really distinctive is that these vegetations can occur on either surface of the valve leaflet, the side facing blood flow, or the underside. They can also occur on the valve cords or even the lining of the heart chambers. This location is quite different from the vegetation seen in bacterial endocarditis or rheumatic heart disease. While often small and clinically silent, they can sometimes cause valve dysfunction or be a source of emboli.
Okay. And you mentioned earlier that while these classic lesions exist, a major modern concern is accelerated heart disease itself.
Yes, absolutely. Accelerated atherosclerosis leading to premature coronary artery disease, CAD, is a huge problem and a leading cause of death, especially in patients who survive the initial onslaught of SLE and live with the disease for many years, even younger patients.
What drives this accelerated atherosclerosis? Is it the lupus itself or the treatment?
It's likely multifactorial. The chronic systemic inflammation of SLE itself is thought to damage blood vessel linings, the endothelium, promoting plaque formation. The immune complexes might contribute directly. Hypertension is common in SLE, especially with kidney disease. And importantly, long-term treatment with corticosteroids, which are often necessary to control SLE, can worsen traditional risk factors like high blood pressure, high cholesterol, and diabetes. It's a complex interplay of disease and treatment effects.
A really serious long-term complication. Does SLE affect the brain and nerves too?
It can. Neuropsychiatric SLE is a recognized and challenging aspect. Patients can experience a wide range of symptoms from cognitive dysfunction, lupus fog, headaches, and mood disorders, to more severe manifestations like seizures, psychosis, stroke, or peripheral neuropathy.
What causes these? Is it immune complexes in the brain?
The exact mechanisms are still debated and likely vary. Possibilities include autoantibodies that might cross the blood-brain barrier and interfere with nerve function, inflammation mediated by cytokines reaching the brain, or damage to small blood vessels in the brain, vasculopathy or thrombosis, leading to strokes or microinfarcts. It's a difficult area to study and treat.
And finally, one more specific organ finding the spleen.
Yes, the spleen is often enlarged, splenomegaly, in active SLE. Pathologically, besides general immune activation, follicular hyperplasia, the characteristic finding is in the arteries. The central penicillary arteries can develop concentric, layered thickening of their walls due to smooth muscle cell and intimal proliferation. This gives them an appearance described as onion skin lesions. While not entirely unique to SLE, it's a strong indicator of the systemic vascular damage happening in the disease.
Okay, we've painted a detailed picture of the widespread damage. Let's synthesize the underlying mechanism that seems to keep this whole process going chronically. You mentioned the TLR and interferon loop earlier. Can we revisit that as the core engine of persistent disease?
Yes, this is really central to our current understanding of SLE pathogenesis, explaining how it becomes a chronic self-sustaining disease. Let's walk through it again. It starts with that initial trigger, UV light, maybe an infection causing apoptosis, cell death, and the release of self-antigens, particularly nuclear material like DNA and RNA.
Okay.
Due to underlying genetic susceptibility, like those complement defects, these nuclear antigens aren't cleared properly. They hang around and form immune complexes with pre-existing autoantibodies.
Right.
Now, here's the crucial step. These immune complexes, containing self-nucleic acids packaged with antibodies, are efficiently taken up by certain immune cells, particularly B cells, which have receptors for antibodies, and plasmacytoid dendritic cells, PDCs, which are specialized antigen-presenting cells.
So the antibodies basically act like a delivery service, getting the self-DRNON inside these specific immune cells.
Exactly, it's a Trojan horse mechanism. Once inside the cell's endosomes, the nucleic acid cargo is exposed to those internal toll-like receptors, TLR7 for RNA and TLR9 for DNA.
Which normally detect viruses.
Right, so the cell's internal alarm system goes off thinking it's been infected. This TLR signaling triggers two key downstream events. One, in B cells, it provides a powerful activation signal, driving them to proliferate and produce even more high-affinity autoantibodies against nuclear antigens, more fuel for the fire. Two, in PDCs, TLR activation triggers the massive production and secretion of type I interferons, IF and I. These are potent pro-inflammatory cytokines that normally orchestrate the antiviral immune response.
So the body gets flooded with this antiviral signal even though there's no actual virus?
Precisely, and this inappropriate type I interferon surge has widespread effects. It promotes the maturation of dendritic cells, enhances T-cell activation, drives more B-cell antibody production. Basically, it kicks the entire adaptive immune response against self-antigens into high gear and keeps it there.
Creating a vicious feedback loop. More cell death, more self-antigen, more immune complexes, more TLR activation, more interferon, more immune activation, more cell death.
You've got it. That positive feedback loop is thought to be central to the chronicity and the relapsing remitting nature of SLE. High levels of type I interferon activity, the IFN signature, are consistently found in the blood of patients with active SLE and correlate strongly with disease severity.
And this model isn't just theoretical, right? The genetic studies, the genome-wide association studies, GWAS, point to genes involved in this pathway.
They absolutely do. While the HLA associations were found early on, GWS has identified many other susceptibility genes outside the MHC complex. And significantly, many of these genes fall into pathways related to TLR signaling, type I interferon production or response, like genes called IRSF55, STAT41, lymphocyte activation thresholds, like PTPN2I2-Porto, which affects T and B cell signaling, or genes related to IL-2 signaling, which impacts TREGs.
So the genetic evidence strongly supports this idea that problems in handling self-nucleic acids and controlling the subsequent interferon response are key.
Yes, the genetics, the immunology, and the clinical observations all seem to converge on this TLR interferon axis as being fundamental to SLE pathogenesis.
Before we wrap up, we should briefly mention the variants of lupus that are primarily skin-focused. They're related but different from systemic lupus, right?
Correct. It's important to distinguish them. The main one is chronic discoid lupus erythematosus, DLE. This manifests primarily as skin lesions, typically raised, red, scaling plaques, often on the face, scalp, and ears. They can cause scarring and hair loss, alopecia.
Does DLE usually become systemic?
Rarely. Only about 5–10% of people with only DLE lesions eventually develop systemic SLE. Patients with DLE alone usually don't have the high levels of ANAs, and especially not the anti-dsDNA or anti-Simin antibodies seen in SLE. It's considered a distinct entity, though, on the lupus spectrum.
Okay, and there's another one, subacute.
Yes. Subacute cutaneous lupus erythematosus, SCLE. This is kind of intermediate. It causes a widespread superficial skin rash, often triggered by sun exposure, but typically doesn't cause scarring like DLE. The rash can be annular, ring-shaped, or papulosquamous CLE bumps.
Is SCLE more likely to be systemic?
Patients with SCLE often have mild systemic symptoms like joint pain and fatigue, and they frequently have positive ANAs. But they have a very strong association with a specific antibody, anti-SSA, also called anti-Rho. They also have a strong association with the HLA-DR33 genotype. While some can meet criteria for SLE, SCLE is often considered its own subset, with prominent skin findings linked to anti-SSA.
Good to know those distinctions. So looking at the overall course of classic SLE, it's known for being unpredictable, with flares and remissions. What's the general prognosis like today?
It's dramatically better than it was, say, 50 years ago. Before effective treatments, SLE was often fatal relatively quickly. Now, thanks largely to the use of corticosteroids to control acute flares and immunosuppressive drugs, like hydroxychloroquine, mycophenolate mofetil, cyclophosphamide, azathioprine, and newer biologics like belimumab for long-term management and preventing organ damage. The prognosis has significantly improved.
What are the survival rates like now?
Current estimates suggest around 90% survival at 5 years after diagnosis and maybe 80% survival at 10 years. These are huge improvements. Patients can often live long lives, although managing the disease and its complications remains a lifelong challenge. Flares are treated aggressively, usually with increased doses of steroids, and then maintenance therapy aims to keep the disease quiet with minimal side effects.
But despite better survival, mortality is still higher than in the general population. What are the main causes of death now in SLE patients? Has that changed over time?
It has shifted somewhat. While acute flares can still be life-threatening, the major causes of death today tend to fall into three main categories. 1. Renal failure. End-stage kidney disease resulting from severe, often class 4, lupus nephritis remains a major cause, although aggressive treatment can often delay or prevent it now. 2. Intercurrent infections. This is a critical one. Patients with SLE have an inherently dysfunctional immune system, and the immunosuppressive drugs needed to control the lupus make them highly vulnerable to bacterial, viral, and fungal infections. Infections are a very common cause of hospitalization and death. 3. Cardiovascular disease. As we discussed, that accelerated atherosclerosis leading to heart attacks and strokes is increasingly recognized as a major cause of late mortality, particularly in patients surviving longer with the disease. Managing cardiovascular risk factors is now a crucial part of long-term SLE care.
That really underscores the complexity of managing this disease long term. Okay, this has been an incredibly detailed deep dive. If you had to boil down the absolute core concepts of SLE for someone listening, the key takeaways, what would they be?
Okay, three main things to remember. First, SLE is the prototype systemic autoimmune disease, attacking multiple organs, mainly through immune complex deposition, type 3 hypersensitivity, though type 2 contributes to blood cell problems.
Got it. Systemic immune complexes.
Second, the root cause is a failure of self-tolerance, likely due to a combination of genetic susceptibility, especially genes involved in complement clearance and immune regulation, and environmental triggers, like UV light, that activate that crucial TLR type R interferon pathway, creating a self-sustaining loop.
Tolerance failure, genetics, triggers, and that interferon loop.
And third, diagnostically, ANAs are sensitive but not specific. The key specific markers are anti-dsDNA and anti-SEMD. Clinically, kidney involvement, lupus nephritis, especially the class 4, is the most significant predictor of severe outcome and requires careful monitoring and management.
Perfect summary. It really does seem like the core problem, the thing that keeps it going, is the immune system getting tricked into thinking there's a chronic viral infection because it keeps seeing its own nuclear debris via those TLRs, driving that constant type I interferon response.
That seems to be a very accurate picture of the central pathogenic process, yes.
Yeah.
A devastating case of mistaken identity leading to self-destruction.
Which brings us to our final provocative thought for you, the listener, to consider. If this relentless cycle hinges on self-nucleic acids inappropriately triggering TLR7 and TLR9 inside immune cells, leading to that pathological type I interferon production, could future therapies move beyond just broadly suppressing the immune system? Could we perhaps develop highly targeted molecules designed specifically to block the interaction between self-Dinorana and TLR7, TLR9 within those endosomes? Essentially, could we silence the false alarm at its source, stop the body from confusing itself with a virus without causing global immunosuppression?
That's exactly where a lot of cutting-edge research is heading. Developing specific inhibitors of those intracellular TLR pathways or blocking the downstream interferon signaling, it holds immense promise. Instead of just dampening the entire immune response, you'd be cutting off the specific aberrant signal that drives SLE. That would be a paradigm shift.
Something to think about. That's all the time we have for this deep dive. Thanks for joining us.
My pleasure.
We'll see you next time.